Chapter 5, Medical Technology. Let's go through this PowerPoint. Learning objectives are on the PowerPoint and both in the chapter. Some good stuff in this chapter. Okay, so introduction. Technology has definitely modernized medicine the way we see it, reduces complications and potential disabilities, increases longevity. We are living longer with more technology, but there's also a cost that comes with that, a cost of research and how to set things up and getting approval. And then once it is approved and in use, somebody has to buy it and then somebody has to maintain it. It's a lot with new devices and new technologies, but it's a good thing. But it's not. It's never perfect. Okay, another cool thing about technology is how once upon a time, like even x-rays, mammograms, MRIs had to all be done in a hospital setting, and now that's not necessarily true. There's outpatient, you can even have certain things done at home. All right, the United States, sorry, I got sidetracked. Oh, the adoption of new technology often differs widely from one country to another. That's what I wanted to say. All right, changes triggered by technology. So these here listed, obviously, yep, that makes great sense. Kind of self-explanatory there. What is medical technology? The application of science knowledge to improve health and efficiencies. Medical science has benefited from developments, chemistry, physics, engineering, and pharmacology. Yes, of course we have. And that will continue. The chemistry makeup of medicines will change. Physics doesn't necessarily change all that much. It is what it is. But different things, technologies, and devices can be developed, of course. Engineering's constant in healthcare, and so is pharmacology. So, nanomedicine is in its infancy, and that is described on page 177. And so, the examples that the book gives, screening tests has been developed for to identify lung cancer in very early ages. So that's nanomedicine. And then nanoparticles are being developed as effective carriers of drugs to target regions in the body that have been difficult to reach using traditional drug formulations. So, still very much in its infancy. It's a new thing, and it will continue to grow with it. Information technology and informatics. There is actually a Master's of Science in Nursing degree that you can obtain for nursing informatics. So we come a long way with informatics also. So information technology is the transformation of data into useful information. There are three categories of IT applications. They are clinical information systems, administrative information systems, and decision support systems. The table on 5.1 gives great examples. Table 5.1 on page 178 gives great examples of medical technologies, just in case you are wondering, how is this applicable to healthcare? They're listed right there. And these are definitely something we use and take advantage of every day in healthcare. Information technology and informatics, I just went over that. Improves efficiency, accuracy, requires the use of IT. Electronic health records. We've talked about this. We will continue to talk about this because this is here to stay in our health system. 20 some years ago, as a brand new nurse myself, we did medical charting on paper. And so imagine being a patient at Wilson Medical and then being transferred to Wake Med. You just hope, just kind of like flying with your luggage, and you hope your luggage arrives. You used to hope that the chart would transfer easily and everything would stay in one place, and you would, as the receiving nurse, you would receive the entire chart from Wilson. Sometimes that was not the case, and vice versa. So now with electronic health records, everything's essentially in one data bank, but not really, because I've mentioned before that our electronic health records are different for each hospital system. And so, yeah, that's a whole nother story, but it's ever evolving. And the fully developed electronic health record system has collection and storage of health information on individual patients over time, immediate electronic access to personal and population level information for authorized users, availability of knowledge and decision support that enhances the quality and safety, and lastly, support and efficient processes for healthcare delivery. So there are, again, good benefits to this. There's also drawbacks. Um, Page 180 and 181, the good things is obviously quality outcomes, improved times, efficiency, but then some people will argue, people groups, whatever you want to call they, when we refer to they said, that the emphasis has changed from patient centered healthcare to institutional priorities like risk management, um, making sure everything's documented properly instead of actually, step away from the computer and look at your patient. So that's the drawback. This slide talks about the interoperability, which is what I was referring to, eliminating the old methods where it came to letters and faxes and just we're literally taking the chart from one facility to another. I'm flipping the page in the book as we go along. By the way, page 82 mentions, and this is something critical to know, this is why not every hospital system has matching electronic healthcare records, but they're expensive and it can take up to 2 years to complete the customization for a hospital facility. So usually whatever these major healthcare facilities started with back in 2010-ish when it was mandated, that's what they're sticking with because they have spent billions of dollars on creating this and the time investment to create it, customize it, teach your staff, get the physicians on board, and help for it to communicate across the facility. It's a big undertaking. The High Tech Act is mentioned on page 182. Read about that. HIPAA law is not going anywhere. So 183, and the last note on this PowerPoint smart card technology. I personally have not seen this in our local healthcare systems, but uh, neat to know that that exists. Good for uh, whoever does use that. I can see where some people would be against it for privacy informations, but when you're seeking health care, you kind of want to have everything out there. Like, when you walk into a physician's office and you meet with your physician, you're going to tell them everything anyway. So I get the idea of a smart card, but what if you were to lose it, land it in the wrong hands, all that private information? So I can see the drawbacks. All right, page 183, we talk about the internet. E-health refers to electronic health delivered over the internet. M-health is mobile health. So that's, where we can do video, which we can do video chatting on the internet with a laptop or tablet or other device or mobile with our cell phones. And e-therapy, this is something newer where especially I would say definitely post-COVID, but even before, because obviously this book was written before then, that you can receive counseling and therapy via the internet online with any type of device. And the book goes into why people do this also. Um, a lot of if a lot of convenience goes into this too, but if your physicians or your healthcare providers, you don't have a lot of confidence in them, you turn to the internet. Or if you have something simple, we turn to the internet, we Google, we ask the internet what it says, and then we can always follow up with. Oh, let me go back to what I just said. I do not condone treating yourself with what you find on the internet, but the accessibility of information on the internet does have some value. So your book describes the differences between telehealth and telemedicine, just some small, subtle differences there. Synchronous technology allows communication to occur in real time when you're dealing with telemedicine. And asynchronous technology employs the store and forward technology that allows us to review information. So, just as a side note, this course is asynchronous. You guys and myself, we do not meet face to face. We don't have that technology available through Wilson yet. And through Barton. Um, but maybe one day we will have that available to us. But asynchronous, myself recording these videos and then posting them, that is asynchronous. So telemedicine, it can be the same way if you, especially if you're, let's just say you're having an upcoming hip surgery and the doctor surgeon wants you to watch post-op instructions, that would be asynchronous. You wouldn't actually meet with that doctor or that nurse to go over that information. They would send you a link of recorded instructions. And then tele-ICU is something I have been a part of and witnessed, and it is a good thing. That is where someone from a central location at the hospital, or maybe even off-site, they actually have cameras and microphones in the ICU rooms with the very, very sick patients. That way, if the nurse who's taking care of 2 or 3 other patients can't be in the room or near the room 24/7, the person monitoring them from a remote can can notice whether the patient's trying to pull out tubes, or if the patient is awake, or if the patient has respiratory distress, or if there's sugar drops. That's where the tele ICU comes in. So it's pretty neat. That is rather new, I would say, within the last decade. All right, factors that drive innovation: our human cultural beliefs, medical specialization, financing and payment. Good old financing. I promise you will always find money somewhere in factors for anything healthcare related. I promise you. Technology driven competition. So patients, every generation's different. My father's generation, grandfather's generation especially, whatever the doctor said was golden, and there was no question, and no, they wouldn't fact check, they wouldn't look up anything. That it's just whatever the doctor said was the way it was. Where in my generation, I'll take what a physician says or a provider says, but I'm also going to do my own research too. Almost like a second opinion. So what I'm getting at is the next generation or the next patient population, they're going to be technology driven also. They're going to want to go to the hospital to have their baby at whatever hospital has the best resources, or the best birth rates, or maybe that hospital that offers free photography. Or I've even heard of hospitals offering steak dinners after you have a baby at their hospital. Very much hotel competition driven, but in the sense of this does happen with technology also. Okay, supply side controls. The book does a good job at, I'm flipping the pages, bear with me. One thing this slide did not mention, and I want to make sure that I do say it out loud, um, page 190 does a good job in describing the conflicts with self-referral and the STAR clause. STAR clause had to be put in place to prevent doctors from referring to their own facilities out of a personal interest. Kickbacks, money, not bribes, but getting a benefit because you referred, unnecessarily. Sometimes it did happen, obviously. That's why there's a law in place. Okay, so back to supply side controls on page 191. Other countries have used government policy to control the diffusion of medical technology. See table 5.2. Let me flip back to that one. Hang on one second. Yeah, so on page 187, that there's a description of MRI units and how they're available. So look into that. Let me know if you have any questions. It's neat to compare what everyone else does on the globe. Government's role, so regulation. Yes, some of our drugs come from overseas. Some of our ingredients for our drugs come from overseas. They are supposed to, of course, be checked and approved by the Federal Drug Administration, the FDA. Government's role, certificate of need. So this is pretty important because this has been in the news lately. Oh, let me back up. I think one of the last sentences on the other slide was talking about regulation of biologics. That's talking about vaccines and blood, gene therapy, tissues, all this new technology that we can use. They do govern that too. The FDA regulates that also. Okay, so back to this slide. Certificate of need. This is a unique process and has just happened recently in our local news. WakeMed has they applied for a certificate of need for a mental health hospital, and I think expansion of another one of their hospitals, satellite hospitals, maybe in Holly Springs, North Carolina. I can't remember. So a hospital can't just take money and build a hospital. They have to apply for a certificate of need with the state. The state has to approve and make sure that there's a population that needs this, where the money's going to come from, how they're going to raise the money, how they'll budget the money, etc. There's a lot in a certificate of need process. I'm going to keep going because I'm going to try to keep it short. Okay, impact of medical technology in the book, page 128. Quality of care, quality of life, impact of healthcare cost. Of course, medical technology does increase our healthcare cost overall. Now, it does make some procedures simpler so that you can charge less, but that equipment that they're using to make it simpler is expensive. So, inevitably, it can cut down on some costs, but overall, it does increase cost. Access is always an issue. Geographically, if you live rural, you are not going to have the same access as someone who lives 15 minutes from downtown of a major city. It is what it is. And I don't know how that would ever change. Flipping through the pages, flipping through the book, assessment of medical technology. Of course, the effectiveness is important, safety, cost effectiveness, benefit. Cost effective analysis incorporates the elements of both cost and benefits. So that's something that is real and people look at. Quality adjuster life year. That is when the estimated benefits exceed the costs. The additional spending on medical care is worth the extra cost, and that's how they measure it. It's a health benefit, is how they measure that. Again, all about the money. We're back to money, dollar values and dollars, which is fine. I mean, obviously, we've got to pay for this. Directions and issues in healthcare technology assessment. That's on page 206. There is little cohesion or coordination between the public and private sector to this day. So public sector being Medicaid, Medicare, that type of federal funding, and some at the state level, and the private sector being the privatized physicians and the private health insurances, et cetera. But I wish they could come together and improve the overall knowledge of the medical technology that is available to us, but that's going to take a lot of getting along, cohesion, and balance, if you will. Page 208, we go into the healthcare reform and medical technology. So the Affordable Care Act imposed a 2.3 excise tax on the sale of certain medical devices. So think about that. If you're a healthcare facility, this $1 million machine is going to make huge strides in your healthcare delivery for your community, but then on top of the expense and the buying it and the training and when you buy a piece of equipment like that, you better buy the warranty because something may go wrong and the upkeep and again training the staff and adding it to the electronic health record that this was done with this machine, etc. But then you have to pay that 2.3 excise tax. That's a lot of money. So that's why when you go for a mobile MRI, maybe of a shoulder, neck, knee, back, foot, maybe in one area, like Wilson will say, it's $1,000, but in Raleigh it's 1,500, or in Greenville it's 1,700, or whatever the case may be. It's a little bit different everywhere you go. There's actually on the news, I think I heard one time, there's a website where you can shop the hospital facilities pricings are listed somewhere. I do not have that handy, but you can, as a healthcare consumer, you can shop where you can get the most medical technology for the cheapest amount. Okay, well, that one didn't frame correctly. See if I can move it. There's the summary. The summary is also in the book. Okay, let me know if you all have any questions, and I'll be more than happy to answer them. Hope you enjoyed this chapter.